credit, as well as 1 hour of Virginia Nurses Association CE credit. Sovah Health is accredited by the Southern State CME Collaborative for providing Category 1 Physician AMA CME. It's also accredited by the Virginia Nurses Association to provide certified continuing education for nurses. The program this evening has been developed to promote patient-centered care and employing evidence-based medicine. The needs assessment behind this program was the public health importance of immunization to prevent serious illnesses within our community. Dr. Baracco, myself, and members of the Sovah Health CME Committee have nothing to disclose as far as commercial relationships. There's no commercial support for the program this evening. It is supported, excuse me, by an educational grant from the Ralph Landis Medical Education Fund, which resides at the Danville Community College Educational Foundation. This fund was created by Dr. Landis, the founder of the Southside Urology and Nephrology Group, upon his retirement, and it serves to support continuing education for healthcare professionals within our community. After the program, you'll receive by email a program evaluation. In addition, as I'll show you on the next slide, we will put a QR code in the chat if you prefer to access the form that way. We do ask you, if you are sharing your logon tonight with someone else, please let one of us know who else is with you so we can be sure they get credit for attendance at the program. The evaluation you'll receive has some 7 or more questions about the program. I always like to highlight the one that asks you, will you be making any changes in your practice based on what you learned this evening? And I always like to remind everyone that this question is for everyone, not just the physicians. Each of us, including the residents, practices medicine or providing care within our scope of practice. And so take a few minutes to answer the questions. We use this information for not only for program planning, but for evaluation. And it's terribly important as far as our program's overall operation. There will be a QR code for the same evaluation form that will appear in the chat box right at the end of the program, which you can use if you prefer that to an email eval form that you'll also get. For the residents on the call, you do not have to worry about accumulating or keeping up with CME certificates. This is done by your residency coordinators, Dara and or Ms. Galvez. We will email the CME certificate to you. So when you fill out that eval form, it will ask you for your email and again, your full name. Please give us your full name so we can have that on the certificate. Please no nicknames, short names, etc., so we can get that right. For nurses and nurse practitioners to receive CME credit or CE credit for the program, you must submit an eval form. Otherwise, the eval forms are elective for the others on the call. For each program we do, I always want to take a moment and thank Mary Kent and Jennifer Goodman for their studious work and helping us put these programs on. They really do all the, if you will, backroom activities that make the programs possible, and I deeply appreciate their help and support with this. I know Dr. Baracco encourages questions. You can put them in the chat or raise your hand. Mary Kent will be monitoring this and we'll get them fed to her, as it were. When you ask a question, once you've asked it, if you're doing it live, please mute your phone so we don't get feedback. You are more than welcome to have multiple questions, comments. In fact, questions and comments just simply make the programs better and more enjoyable, I think, for everybody. I'll highlight for you the last 3 programs that we are going to have this calendar year, and these will be throughout the month of November, beginning November 6th, when we're delighted to have Dr. Christopher Holstead, the director of the Blue Ridge Poison Control Center at the University of Virginia in Charlottesville. Dr. Holstead manages as medical director that process. It is his office or his department that whenever a patient presents with an overdose, so he's the one we call, or that his service. He'll be doing 2 programs, one on November 6th, which will be talking about the street drugs that are out there currently and the drugs leading to misuse and overdose. And then something really helpful is how you interpret both the limitations and benefits of urinary drug screens. I don't know that you can find this information anywhere else. He'll return a week before Thanksgiving and talk about envenomated patients. Those are like snake bites, spider bites, etc. Again, a unique bit of information. Between his two talks on November 13th, Dr. Boland from the nephrology division at Wake Forest Baptist School of Medicine in Winston-Salem will be talking about diabetic nephropathy. That, of course, is the underlying disease for 75% of people starting dialysis, not only in Virginia, but in the nation. It currently is a disorder that is preventable. And now we have 4 classes of drugs, which each independently and when added to other agents can slow the progression once diabetic nephropathy begins to end-stage renal disease. So this is something that I'm sure all of us in our practice see, and it's something you really do need to know about. All that being said, I'm delighted to have once again introduce Dr. Allison Baracco, who is the medical officer for the Virginia Department of Health here in the western part of the state. She's based in Stanton, Virginia. You'll recall she did a wonderful program for us on syphilis, and we really, really thought she was such a good speaker and effective communicator. We wanted to have her back for the topic tonight on the current recommendations for annual vaccines. As you'll recall, Dr. Baracco began her educational journey at Auburn, where she graduated summa cum laude in biomedical sciences. This was followed by her MD at the University of South Alabama, that's in Mobile, Alabama, and then internal medicine residencies at Eastern Virginia Medical School, and finally her fellowship in infectious disease at Eastern Virginia also. She currently is the medical director for the Virginia Department of Health and the Central Shenandoah Health District, where she lives and works. As I said, she's based in Stanton, Virginia, and Fishersville, Virginia, right in the middle of the southern part of the beautiful Shenandoah Valley. So, Dr. Baracco, thank you so much. If you'll bring your slides up, you should knock mine off, and we so appreciate you doing yet another program. Thanks a bunch.
Okay, my apologies. I forgot to do my job and bring up my slide set, but thank you. It's an honor to be here again. I appreciate the positive reception, and I hope I can do this topic justice.
We can see them. They look great.
Along with serving as the acting health director in Central Shenandoah, I am a medical officer for West Piedmont, so which serves Henry, Franklin, and Patrick County, and so happy to be here. They provide vaccinations to the community, along with, I know Dr. Spillman's on the line, the Pitt-Dan community. So as we talk about vaccines, think of your health department as a resource, but we'll also talk about, I'm an advocate for getting shots into arms in the office too. So I hope we all can learn something today. Today, I brought you some weather that can help inspire us to think about this respiratory virus season. It's chilly and cold here in the Shenandoah Valley, and I heard it is down your way as well. I think it's foggy just across the western part of the state. And that makes us start to think about our respiratory viruses. As I know, I spoke to a pediatrician just a week or two ago in my community, and she said it's been unusually quiet as far as the sick visits in her pediatric clinic. But I think we all know that crystal ball there says things will probably be changing soon as we're ending October in just a few days. So first, I want to talk about our outlook or overview of the past season, what we might be able to think about this season, as I think some of this information helps inform you for what you need to be educating your patients, or just different talking points that can help us consider what we should be telling our patients. So during 2024 to 2025, the CDC estimated 11.5 to 18 million COVID-19 illnesses, 2.8 to 4.2 million COVID-19 outpatient visits, 320,000 to 480,000 COVID-19 hospitalizations, 37,000 to 56,000 COVID-19 deaths. So still a significant number of COVID activities such as hospitalizations and death, despite this becoming more endemic. And overall, the activity in Virginia was similar to the past few seasons. There's typically a peak between December and February. Last year, you can see it was almost a bimodal peak. And on the right side of the picture graph here, you can see in Virginia, there's been low levels of activity of our respiratory viruses on the western side of the state, minimal on the right. But as we've noted in the offices, it's been quiet, but things are starting to pick up, especially we're finally seeing with RSV a smaller uptick of our age 0 to 4 children presenting with RSV illness. So looking back, 2024, 2025, as I noted, it was a bimodal peak. It was a little later, though it was pretty similar to the previous 5 seasons. But what you should know is this actually last year was considered a high incidence year, or a severe year in regards to hospitalizations, which were much higher than preceding seasons. And so last season, along with the record number of deaths, you can see here the number on the CDC chart, the predicted number of deaths, hospitalizations, medical visits, and illnesses across the United States. There was the highest number of pediatric deaths during a regular non-pandemic season since they've been tracking hospitalizations and pediatric mortality. Last season, Virginia reported 6 influenza-associated pediatric deaths and 366 influenza outbreaks. Something that I don't know if everyone recognizes, and I, in fact, didn't recognize it until a podcast I listened to, the infectious diseases provider, and brought this out when they were talking about a study about influenza vaccine. Children under 5 have the highest hospitalization rate of any age group for influenza. We talk a lot about how we want to prevent our older individuals, those over the age of 65, from being hospitalized, and that's certainly important and certainly significant. But I did not realize that children under 5 have the highest hospitalization rate. In Virginia last year, 6 children in Virginia sadly died of flu, and approximately 300 across the nation died. 89% of the children were unvaccinated, and approximately 50% of those had an additional comorbidity, which means 50% were considered healthy prior to that flu event. But that just those statistics emphasize to me the importance of getting flu vaccination into the arms of both children and adults in the entire community. And it does reinforce the recommendation that for people, for influenza, we should be vaccinating everybody that is over the age of 6, except for there's very few exceptions, like in a previous allergic reaction and such, but almost everyone needs to get a flu vaccine. So last year, when we look at laboratory testing, most people had influenza A at the end of the season. There was a small blip of influenza B. That's quite common. But influenza A typically predominates. And with subtyping, the majority were H1N1 and H3N2 strains, which is quite common or typical for influenza. And so I bring up this respiratory season evaluation here and the MMWR evaluation. Since they've been looking at flu seasons and the severity of each flu year, there has yet to be 2 years that have been considered high in a row. So we have 2024, 2025 is considered a high season. The forecaster predictions are that we're going to have a similar season than last year, but the question will be, will there be 2 high seasons in a row, which we've yet to see, or will it be moderate? But we should anticipate similar trends from last year, especially, I mean, it just dependent on how well we vaccinate our community. But if we don't see any changes in vaccination in the community, we can anticipate the same trends as last year. Respiratory illness hospitalization outlook. The CDC forecasters estimate hospitalization burden would be similar or lower than last year. And I think they say lower only because last year was a high year in regards to hospitalization. And the flu season differed substantially from experts' assessment. Then the flu peak would be similar or lower than previous seasons. So, some of the forecasting we don't know until we get to it. We see if there's any immune escape of these viruses, but nonetheless, we can anticipate probably a similar year as last year. We already talked about the influenza-associated pediatric mortality of the previous year in the a couple slides before, but these are just some graphs looking at the data. And as far as our 2025-2026 respiratory season outlook, we do have the benefit of looking at what happens in the southern hemisphere. And usually the strains that predominate in the southern hemisphere are the same strains that predominate in the northern hemisphere in the fall season. So looking at the southern hemisphere influenza vaccines, the seasonal vaccination reduced influenza-associated outpatient visits by approximately 50.4% and hospitalizations by 49.7%. That's similar also what we're learning about COVID vaccines, or they're decreasing hospitalizations about 50%. So, not great, not perfect, but we look at the data in regards to the morbidity and mortality associated with not receiving these vaccines, and it's certainly an argument that, something is better than nothing. And this doesn't even incorporate, data looking at things that have been well studied with, especially with the influenza vaccine, is that vaccines are protective against, and this is not 100%. Again, it's kind of reduced like our flu vaccine efficacy in regards to hospitalization, but they do help reduce the risk of things like post-viral associated myocardial infarctions. So there is, as far as the pro-inflammatory response after a severe viral illness like influenza, there is a benefit of receiving a flu vaccine. So overall, looking at our respiratory season outlook by condition, COVID-19, we know as of September 21st, there was a little summer surge. We've noted since the pandemic that there's been a smaller surge followed by more traditional respiratory season winter surge. And so as of September 21st, COVID from the summer had been declining in Virginia nationwide. And as far as influenza is concerned, we have yet to see a lot of flu activity in the state. The activity is low overall. And looking at the map, you can see it is that light green is low activity and the dark green is minimal activity. We don't know if we'll see 2 high severity seasons in a row. Statistics say we won't, but they're also predicting we'll have a similar season as last year, which was significant in regards to hospitalization. And then in regards to RSV, I think is and the warm and fuzzy story. So with our new immunization products that became available, we are seeing reduction in hospitalization due to RSV, both in our infants and our older adults related to RSV. Now, the RSV activity in Virginia is low. Usually that is the first virus to peak. One year I remember hearing the peak was around Halloween, which is like in a couple days. So clearly we're not there, but we'll probably see RSV peak, and then see flu activity and COVID activity always around the holidays. When I was working in the hospital, I was always hopeful. I knew it was coming. We couldn't avoid it, but I was always hopeful that it would be after the Christmas, New Year's holiday. So I had more time to enjoy it with my family. As we know, there's with the higher number of outpatient visits and hospital visits, usually you're busier as a clinician. So now I want to just briefly, I'll look at the chat for a second. I don't see any questions, but feel free to leave some in the chat. Mary Kent will help me with that. You can also raise your hand. I want to go through a couple tools that we use in public health for respiratory illness surveillance, just for your awareness of how am I providing you this data? How do I even know this information? Where can we access this information? So I'm providing a few slides just for reference and your awareness. There are multiple resources that public health uses, both nationally through the CDC, usually partnering with all our state labs to help track illness. The first thing is laboratory surveillance. So when there's a positive laboratory report for flu or COVID, those items, those lab reports are reported up to the state health department, and that helps us track the burden of disease. Of course, we know that not everybody goes and gets tested for the flu or COVID. So we use this as one data analysis point, but we also use other data points to help us assess when it's the peak of respiratory viral season. The second thing we do is called syndromic surveillance, and that is using data from emergency departments and urgent care visits to help determine the respiratory illness activity in a region. And so that is using data looking at people coming to these locations with respiratory symptoms to help us better learn when we think a respiratory virus is going to peak. And knowing that COVID and influenza and RSV are the most likely pathogens to lead to hospitalization or emergency department visit. We also look at pediatric mortality surveillance. This is something that is immediately reportable, so it needs to be reported within 24 hours. And VDH confirms the cause of death and rules out other possible diagnoses before this is an influenza-associated pediatric death is declared. And this is tracked on the dashboard. We also look, an important thing that we look at is outbreaks, and that provides insight as to how much respiratory disease is spreading in the community. And I can tell you that before we see any community peaks, like just as general trends, looking at this other data, I'm hearing from my local epidemiologists about the outbreaks they're tracking at this nursing facility and that nursing facility, and that's usually where I think the party gets started, and then moves out to, and also in schools. But we really see outbreaks. That's one of the primary places where we're tracking activity, is in like nursing facilities, for instance. But also sometimes we do receive reports from schools and daycares, and we investigate. Ideally, VDH collects 3 to 5 samples and submits them to the state lab to help us identify the pathogen that is causing the problem. Right. And finally, we use wastewater surveillance. You can see the dots on the map. Those are areas where VDH is tracking through wastewater the burden of certain pathogens like COVID-19, for instance. And so tracking that over time can help us predict when we might see a surge of viral pathogen in a community. So we also have non-reportable pathogens. Respiratory syncytial virus, or RSV, is one of those, which can co-circulate while influenza and COVID are increasing. We talked about how the activity is currently low, though we can expect that to increase soon. We'll start to switch gears. I do want to let you know that VDH is promoting the Little Things campaign. There's a lot of fun marketing items, and I think some of those are, if you go to the website, some of these posters are kind of available, or things to print for your patients and community are available off the Virginia Department of Health website. This year we're focusing on the little things. So asking community members to get immunized, cover your mouth, hand washing, going back to the basics. These are the things we should start with. As medicine gets more complicated, of course, prevention is always best. And then also I included key messaging for the community. These are not things that are new or novel or you haven't seen before, but I included this in case you're going back to the slide set and you just need to prepare a punch list for your clinic. These are just some staple items we should think about when we're talking to either our patients or families. If they're asking, what can we do? How can we prevent this from happening? We have to start with these little things right here. All right. So now we will move on to a case study. And this is just to help with our discussion and move us pivot into vaccinations for the respiratory season. We have a 33, this is somebody who's probably very familiar to all of you and many of your clinics in some form or fashion, but we have a 33-year-old previously healthy woman. She's a traveling nurse. She has 4-day history of sneezing, runny nose, nasal congestion, sore throat, ears are full. She has a cough that's a little productive, myalgias, malaise. She doesn't have shortness of breath. She doesn't have fever. She doesn't have chills. You learn that her toddler was recently ill with a cold, mostly better now, snotty nose. This suggests a common viral transmission, but she comes to you seeking medical attention because she's about to travel for her job and she wants to start antibiotics just in case a bacterial infection develops. Vital signs are normal. She has some mild erythema in her pharynx, mild erythema of the tympanic membranes, but no fluid. Mostly just a normal exam. Her lungs are clear, nothing concerning to you. And you're pretty convinced at this point she does in fact have a viral upper respiratory tract infection. And she's a nurse, so she comes to you with a lot of knowledge and she wants antibiotics. We've all been there, and the question is, what do we do with this person who they came in for a reason. They have a lot of knowledge and probably want to walk out with something in their hands, like a prescription or something. I guess today in 2025, you don't walk out with a prescription, but something's called in or electronically transmitted to her pharmacy. So for viral upper respiratory infections and a lot of infections that don't require antibiotics, as an infectious diseases specialist, I find that these are appointments that do in fact take longer than just providing someone with an antibiotic prescription. And I'm probably preaching to the choir a little here, but I think it's important that we validate symptoms. If we are dismissive and say you just have a virus, only have this, people do get defensive and they probably do feel terrible. So we need to validate, even if it's a virus, they can feel terrible. These tips below, I mean, you can provide home remedy prescriptions. I think the biggest one on the list is emphasizing the need to rest. I think sleep is super important in any recovery, instead of prescribing antimicrobials. And this is a hard task, and it's not done as often as it needs to be, but we can also discuss our rising antimicrobial resistance, and just in case antibiotics just are not going to help as a whole anymore. But ultimately the person usually, they came in for an appointment and they usually want something. So what else can we do for this person? They are a healthcare provider, and maybe, just maybe, they need a vaccine, because this was unlikely the flu. They'd be much sicker. So when is the appropriate time to vaccinate this person? The CDC notes for mild illnesses like this patient that it's okay to proceed. We should not delay vaccine due to mild respiratory illnesses. When somebody has like a pediatric patient with a fever and we're concerned that the vaccine too has fever as a side effect, we might want to defer that. We don't want to exacerbate the fever by providing the vaccine at the same time. But it's only because we want to avoid that. It's not because of any change in efficacy of the vaccine. And in severe illness, we should defer until recovery, so we can prevent any confusion between illness versus vaccine side effects. But I do encourage a lot of people, when their patients are hospitalized, so for our hospital patients, they check that box like, oh, they should just get it when they follow up as an outpatient. But in fact, we should just wait a day or two. And once they start to improve, we really should get that vaccine into their arm. Is there a more vulnerable host? They could be going to a facility where there's a heightened risk to be exposed to these viral respiratory infections before we even knew there was time. So getting that vaccine in them while they're in the hospital is important. Now, for immunocompromised, the IDSA and CDC guidance for timing and vaccine type is available. The IDSA just did release updated recommendations or guidelines on their website for immunocompromised hosts, starting with COVID vaccines, and plan to expand to RSV and influenza is their intention. All right. So the rationale, there have been several studies, and all those studies are outlined on the CDC website, that mild illness does not affect our vaccine response or the safety of the vaccine. Delaying the vaccine, anytime we just put that vaccine off to the next appointment, decreases the uptake and the protection. And then severe illness could confound interpretation of side effects. So again, CDC CDC and IDSA both emphasize proceeding when illness is mild. And so I think some people are really good about it and some people are hesitant, but hopefully, you can look at the CDC website and see the evidence that shows you this is safe and probably the best time to get the vaccine in the person's arm. And then they actually leave and you gave them something that they can say, well, at least I got my flu shot while I was there because I'm a nurse and I needed to get it for my work assignment anyway. In regards to what to tell this person about returning to work, this could be a full discussion in itself. I just want to make sure people are aware that the Virginia Department of Health just released some guidance. It's not a mandate. They are not formal guidelines, but it's guidance on return to work for healthcare personnel. And what this is that, the CDC, as we all know, had a lot of changes starting in January of 2025 and a depletion of a lot of the leadership, sadly. And there's a healthcare infection control advisory committee, the HICPAC committee, that dissolved in May 2025. They had they had a meeting in the fall of 2024, and they had been working on releasing new CDC guidance on return to work for healthcare providers. Why is this important? It's just more practical. It takes away, I know some of you probably on this call have been told, to come back to work, you need to check a COVID test at home. And if it's positive, stay home. If it's negative, you can check another one in tomorrow, and if it's negative, you can come back to work. And it takes away chasing a lot of these tests. What they learned is that most people, the highest burden of disease and infectivity are during the first 3 days. And then by day 9, most people are not infectious at all. So it allows people to return to work when for both COVID and flu when they've had at least 3 days after symptom onset if they're improving, and just much more streamlined guidance for anyone in healthcare. We know the community guidance was simplified by the CDC, and I would still refer your patients to that guidance. But for your healthcare providers, you can find this now. You can see the link at the bottom of my slide if you need it for your particular clinic and want to reference it and see what your current practice is and how you can perhaps simplify it. I recommend you go to this guidance, and it is basically the CDC guidance that VDH adapted because we don't anticipate that the CDC is now going to be able to update what they were going to publish. That's how this all came about. So we will pivot. I don't see, why would you do swabs for strep and influenza given that as a nurse she is exposed to many ill persons? Oh, is this in regards to my case study? If it's in regards to my case study, I just made up a case for the purpose of discussion of when to vaccinate. I didn't really say that the influenza, I guess you could have done those, and then my answer would have been as far as the case study, the pretend case study is that person did not have strep and they didn't have influenza. But good point. I didn't talk about what testing to consider for her, so I appreciate that.
You're muted.
Sorry, I don't know how I did that. So we're pivoting to vaccines, and I hope what you learn is that there really isn't any substantial changes at this point, but we do have a key role, especially as unfortunately, I feel like some politics have gotten weaved into vaccination all of a sudden to address hesitancy and misinformation and kind of stick to the science. We need to be clear, provide empathetic communication, emphasize protection and safety, and the CDC emphasizes, and I encourage same-day vaccination. In my practice, I was highly successful in my infectious diseases practice, even when people were hesitant, and I know they would have never went to CVS to go get their flu shot, of convincing them to get their flu vaccine that day at that appointment, and they left. And I felt good about it, and they felt good about it. And they didn't come back at the next appointment, and they weren't upset at me about it. So I think that we have that resource and tool. I know with Medicare now, a lot of our older patients have to go to pharmacies, but when you have the vaccine available and you can give it to them, one study in an emergency department showed that 46.4% of unvaccinated individuals would accept a vaccine if offered during an ER visit, and the vast majority, 86% of those, would have accepted any missing vaccines. So I know there's reasons why it's not, vaccines are not provided in the ER. I know it's multifaceted, so we won't go down that rabbit hole, but this study just kind of suggests that patients will receive things and better if we offer them at the time of the appointment. So if we have a vaccine available, that is our perfect opportunity while they're in our office. When we look at vaccines, and so our patients, a lot of them may have hesitancy, especially with all of the confusion related to what's happened with CDC and ACIP guidance over the past several months. So vaccines, we have to remind patients that vaccines are actually, in regards to FDA approvals, they go through some of the most stringent approval cycles of any medication that is FDA approved. There are multiple phases. Phase 1 uses a small number of healthy volunteers just to look at safety. And then phase 2 looks at both safety and efficacy with just hundreds of volunteers. Then phase 3, the largest phase, does look at safety, efficacy, side effects, and compares. That's when we compare to unvaccinated groups as far as efficacy. And so only when it passes all those phases and we learn that the benefits outweigh the risks, the FDA licenses the vaccine. But after that, there is continuous post-vaccine monitoring. We know that every patient is advised of, we have to report any vaccine adverse events as providers. We have to report those, and then the CDC and FDA compile all of these reports. They look for trends, perform any additional studies. There's also a public use data set available for anyone that wants to look at the safety of the vaccine. So we have this continuous quality control mechanism for vaccines, which is unlike other medications that are FDA approved. So why should people get the influenza vaccine? We know that we hear a lot of misconceptions. I get the flu every time I get the flu shot. I feel a little wimpy that evening, but I certainly don't get flu symptoms. So it's variable as far as what symptoms people get when they receive a vaccine, but we know it's not a live virus. We also know it's not robust as far as eliminating your chance of getting the flu, but again, we need to emphasize and talk about the reduction of risk. So it reduces the risk of flu illness by 40 to 60% when vaccine matches circulating strains. And then a CDC analysis looked at the prevention of hospitalization, and there was a 41% reduction in adults aged 18 to 64 and 44% reduction in adults that are over 65. Among children, vaccination cut flu-related ICU admissions by 74%. So it does save lives and it protects vulnerable populations. And we talked about that sad population of the pediatric morbidity and mortality, those that are hospitalized or die sadly in that mortality portion, 89% of those children were not vaccinated. I can tell you that my kids get vaccinated every year. They always have, and there's always flu in the schools, and my kids just don't get the flu. So, I think, for the sheer, I mean, there's a lot of community and economic benefits. For the sheer sake that it prevents me from missing work and them from missing school, that's a win. So we have millions of lost days that are avoided. It does contribute to herd immunity and protects those who cannot be vaccinated, as well as those that maybe they are vaccinated, but the uptake or their immune response is weaker than the kids that are getting the vaccine. It reduces healthcare system burden and leads to faster recovery. So for this year, again, we have for people that are aged 2 to 49 years of age, the live vaccine, it's a nasal home administration that is available again for those who are not immunocompromised. They have a choice of receiving that or the traditional vaccine that is looking at the age 65, we have the high dose quadrivalent vaccine. And then for everyone else, they can get, or even those over 65 can get a quadrivalent adjuvant vaccine. Everyone else would get either the live vaccine or the quadrivalent adjuvant vaccine. And frankly, for anyone over 65, if they don't have access to the high dose, giving them the quadrivalent adjuvant vaccine is good. It's better than missing out on an opportunity and being exposed to flu. So the one recommendation from the ACIP that came out June 2025 is that vaccines should be free of thimerosal. And so what does that mean? How does that change our practice? It really, for the most part, it doesn't. There were a small amount of people receiving if they received a flu vaccine from a multi-dose vial, they may have had that preparation in the past, but it was really a very small portion of the people receiving the flu vaccine, and they don't anticipate from a supply standpoint that this is going to impact the supply. But the rationale of making that change is a bit concerning. So I thought I would just take a slide to dive into what thimerosal is and why it was placed in vaccines in the first place. And so then we can so then you just have a little more knowledge in regards to why that change was made and how we can educate patients if they have concerns. So it is a mercury-based preservative that we have been using since the 1930s for both medications and vaccines. And what it does is it prevents bacterial and fungal growth, which would also be detrimental if we were injecting people with medications that had bacteria or fungus in them. So this was a remarkable invention, and since that time there have been multiple studies that have found no harm using these low doses in vaccines except for site reactions. Nonetheless, in 1999, the Public Health Service and the American Academy of Pediatrics and vaccine manufacturers all agreed that this should be reduced or eliminated in vaccines just as a precaution. And just to note, it was never in the MMR vaccine, which we know has its own controversies. So Thermacell was taken out of all childhood vaccines in 2001. And then in 2010, the CDC did have a large study where they showed prenatal and infant exposure to vaccines and immunoglobulins that contained this Thermacell did not increase the risk for autism spectrum disorder. But despite all of this evidence, the ACIP did recommend using only single-dose influenza vaccines that do not contain Thermacell. So I just wanted to go through the background of what the change was all about. All right. We will switch gears again. This is more of a happy story to me. RSV is a success story on both ends of the age spectrum. So before the introduction of universal RSV immunization for infants in 2023, RSV was the leading cause of hospitalization among U.S. infants. The data from real-world effectiveness studies have estimated that maternal RSV vaccine offers 70 to 80% RSV-associated hospitalization. In 2024 to 2025, there were 3.6 to 6.5 million RSV illnesses, 10 to 23,000 deaths. The infant antibody was 90% effective at protecting against hospitalizations for infants. So we have two modalities. We have either the mom can get vaccinated at 32 to 36 week gestation, or regardless of, that's the preferred time, but regardless of the time that it's RSV season, if the mother gets vaccinated during this 32 to 36 week gestation period, that is the current recommendation. Or an infant that is born and going to be less than 8 months during the first RSV season, so September through January, should be given the infant monoclonal antibody. And then high-risk children can get a second monoclonal antibody the second season. So they get passive immunity but not long-term immunity through this strategy. In 2023, the recommendation came out, but there was no supply. It was really sad. There was no supply of there was supply. It was just very scarce, I should say, of the infant monoclonal antibody. And then insurers had yet to receive or have because there wasn't published data about use in mothers, it was hard to get reimbursement for maternal RSV vaccine. So 2023, the AAP saw how convincing the data was that this prevented hospitalizations, but there was no supply to really get a robust national response. But that kind of changed, and we're seeing how effective this vaccine is. So implementation tips, first you would confirm if the mom received her RSV vaccine. That's preferable for most situations. Otherwise, you would administer the monoclonal antibody, nirsevimab. There is a second one too, at hospitalization or during an early outpatient visit. And then you should coordinate with well child visits and EHR prompts to avoid missed opportunities. Counsel patients on timing, seasonality, and hygiene measures. So on the other end of the age spectrum, we have RSV use in our adults over the age of 60. what we learned through the study is there is a 92% effectiveness against ER visits or hospitalization in those over the age of 60. And then those over the age 75, the protection was 95%. A 90% effectiveness against severe outcomes in ICU or mechanical ventilation. So this is significant. Exceeds influenza, pneumococcus, and COVID-19 vaccines. So I find this a tremendous outcome and rationale for vaccinating our adults.
Dr.
Vaccine, yes, ma'am. Yes, ma'am.
There is a question in the chat whenever you want to take a.
Oh, okay.
I can look at that.
Um,
Do you want me to read it or?
So it says, good evening. Beyond the immediate public health benefit of preventing acute illness, what are some of the long-term effects of annual vaccination for all major respiratory viruses on population level immunity, vaccine effectiveness over time, and public trust in vaccine programs? That is a great question. I'm trying to think. It seems like we have multiple questions rolled into one. I guess if you want to unmute yourself, I guess I'm looking for a little more, if you could provide a little more information of what you're asking, that would be helpful to narrow it down a little bit. Sally? And in the meantime, actually, I just started to unmute. Are you able to, or you could ask a second question in the chat and I'll come back to it. So I'll talk first about the RSV folks, and I will get back to your question, Ms. McIntosh. Looking at our adults, sadly, despite this efficacy data, only 34% of our adults that are 75 and older have been vaccinated for RSV, and 31% that are high risk at age 60 to 74 have been vaccinated. So we're looking at more data to see if this should be expanded to adults age 50 to 59. At the beginning of their investigation, there was some signal that there were some cases of Guillain-Barré, which can be caused by infection, and they were not sure if it was the vaccine or infection. So they really, in 2024, I'm going to show you what the current CDC recommendations are, focused on how effective it has been in older adults and those with comorbid illnesses, instead of expanding the age recommendations. But I think we're going to see that that the efficacy outweighs any harm, and they have really not seen the signal for Guillain-Barré extend after the initial. It was just too small of a population to really tell what was happening. So right now, the CDC recommends 1 dose of RSV vaccine for anyone over 75. And we saw that we have a large population that would benefit from receiving it. And then 50 to 74, if you live in a nursing facility or if you have a comorbid condition. And it's a one-time only dose for now until we obtain more data. I see that we have 10 minutes left. So, and I only have COVID to discuss, and then really I'm going to be moving into just some reference slides. What are the true contraindications for influenza vaccine, if any? Is Guillain-Barré for any reason contradicted for influenza vaccine? So if you truly had Guillain-Barré associated with receiving a previous flu vaccine, then you would not want to get that flu vaccine again. But Guillain-Barré, in fact, you can see that more if you look at trends associated with actual infections than with vaccines. The true contraindications, there used to be one if you had an egg allergy. Most of them are egg-free, and even the ones with a small egg component they have identified that it wasn't substantial, and you can still get that vaccine, but there are egg-free formulations for those people that that don't want to receive that. Also, for the live, that intranasal one, if you're immunocompromised, it's contraindicated because it's a live attenuated vaccine, and they would recommend getting the inactivated quadrivalent vaccine instead. So there are very few contraindications. If you had a true allergy to a vaccine, then you would not want to, like an anaphylactic allergy, that is, to a vaccine, then you would not want to get the vaccine again. Right, so the second, as follow-up to my question, mandate versus recommendation, vaccine fatigue, healthcare burden, cost, and equity. So I'm actually, as we go into COVID vaccination, we're going to talk about shared clinical decision making, and I think that having mandates before turned off some people, but now the CDC has moved to shared clinical decision-making for flu vaccination. I do think vaccine fatigue has played a role, and some confusion. I mean, frankly, during the middle of COVID, people were confused if they got the COVID vaccine or the flu vaccine. They would tell me they already got their flu shot, but they got the other one. Healthcare burden, cost, and equity. I think that the studies show that that vaccinations, frankly, are quite cost effective. If we can prevent hospitalizations, then it's one of the most cost effective items that we have in healthcare. So I probably didn't answer your question extensively, and I apologize, but we will move to the COVID slides, and then at the end, if there's additional questions, I'd be happy to take them. So when we look at COVID-19 vaccination, it was pioneered by Operation Warp Speed, and during Operation Warp Speed, we had nearly 85% of the U.S. adult population vaccinated, which is quite a contrast to 23% of adults currently following the CDC's most recent seasonal booster recommendations. Global statistics show that COVID vaccines averted more than 2.5 million deaths between 2020 and 2024. The same study showed that 5,400 one life was saved for every 5,400 vaccines administered. And looking at more modeling, the vaccine was estimated to prevent 14 million to 19 million deaths globally. In the U.S., modeling shows that between 2020 and 2022, 3.2 million deaths and 18.5 hospitalizations were averted. And we know that, the biggest thing, I think the biggest take homes when we're counseling patients is figure out who your target audience is. We're not going to convince everyone, but I am pretty, when I'm counseling my patients, if they have, if they're immunocompromised and have a risk factor, or they are older, I talk to them, counsel them specifically about their risks. I think that's what people want to hear, is about how this is going to affect them. Some people I'm not going to convince, and if they were lower risk, I will still tell them that I think that's the right thing to do. But if they walk out my door and they don't want it, I certainly never force it. But for older people, I'm a little more, I'm a little more strong voiced about people that if there is really good evidence, like for our oldest patients decreasing their risk, I'm going to share that with them, as we know that in one study, 90% of the 2.5 million deaths averted were among people over the age of 60. So I have these charts, and I know you'll have access to the slides. The FDA advised vaccine manufacturers to update to the monovalent JN1 lineage, targeting the LP81 strain for fall 2025. So FDA first made their recommendations in 2025, and it was for people over the age of 65 or those less than 65 with at least one high risk factor. And then the CDC adapted finally to make it that anyone can receive the vaccine with clinical decision making. And part of this is to allow, I think, in order for a vaccine to be covered, it either has to be FDA approved or approved by nationally recognized organizations like the CDC. And if we go outside CDC guidance, sometimes insurers don't have good uptake on paying for reimbursing for vaccines. So if I have a patient and I'm talking to them about COVID and getting a vaccine, I look at what their comorbidities are, which do include pregnancy as far as high risk. And on the CDC website, they have a nice link looking at all the data that shows why these are higher risk conditions that led to more severe COVID-19 illness, including higher risk of hospitalization. This list below is not exhaustive. It is the full list is on the CDC. So the CDC did change their guidance to shared clinical decision making. I want to make sure everyone understands that this is a collaborative discussion. So, it's not a default like a lot of vaccines the recommendations are not shared clinical decision making, but it's more of a default of a healthcare visit. So this is a collaborative discussion between you and your patient. And to help everyone, I think it's important to know that the CDC defines this as anyone who provides and administers vaccines. So it includes our primary care providers, specialists, advanced practice providers, but also registered nurses and pharmacists can perform this duty. So we don't have to feel like it has to come from a physician. It can come from this whole team of healthcare providers. And so they are using this to help facilitate, I know it's the ACIP guidance, but also allow a more broad recommendation for COVID-19 vaccination. It appears to be covered this year through most payment mechanisms thus far. And prior to the CDC making the recommendation of shared clinical decision making for anyone over the age of 6 months, the commissioner, Dr. Karen Shelton, did write a standing order to allow pharmacies to prescribe the medication. We know for a short window in the fall, physicians were having to send prescriptions into the pharmacy, and that was related to our Code of Virginia and the scope of the practice of a pharmacist. They are not allowed to administer a vaccine without either a written order or a standing order or being a CDC recommendation. So once that was in place, the commissioner was able to revoke her standing order, and the pharmacies are still providing vaccine to anyone age 3 and up. Those that are between 6 months and 3 years can go to their provider for the vaccine or a local health department. So, and it's 8:01, so I know it's getting late. I want to make sure everyone knows. I just have a couple slides. As far as the other recommendations the CDC made, they recommended separating. There is a MMR and varicella vaccine combined, and they recommended that it be given separately. Well, this was only really 15% of the vaccines that administered were the MMRV. So that is not a big disruption. The first doses were always given separately anyway. There's only some of the children given the second dose at age 4 to 6 years that were given the MMRV together. Now it has to be given separately. So it's pretty sad. I mean, some children, there's a lot of people that have anxiety related to vaccines, and now they get an extra shot. But does it really change things overall? Not really. We're still able to give it on the correct schedule. And these are schedules that have been, when we think about pediatric infectious diseases, academic scientists, many of them have spent their careers on developing the schedules and looking at the amount of immunity that you receive when you receive a certain combination of vaccines at a certain time. And it's amazing the science behind it. So any disruption of schedules would be disturbing, but we haven't seen any disruption of the vaccine schedule thus far. And we already talked about COVID. That was the other changing it to shared decision making. We could have a whole nother discussion on childhood vaccines, so I will not go through that. This is a summary of 2025 vaccine indications. For anyone who would like that as a reference. And I wanted to point people to these resources are available for the public from the CDC and BDH if you feel like, if you like to track what's happening in regards to respiratory viruses. I wanted to share those with you this evening. There's toolkits, dashboards, all accessible to you. So just remember the little things to keep our community and families well. I'm going to go to the chat and see if I can answer any questions, and then I'll take any more. Dr. Spillman would like to receive the slides, of course.
It's done.
And go ahead, Mary Kent.
Oh, they've been sent.
Okay, wonderful. Any other questions for me? I apologize for going over. I thought I was going to be under the hour, so my apologies.
Don't worry, you're in the box. You were just great. That's not a problem. Let me, while we have people on the call, and I don't know if Dr. Spillman's still with us or one of the local public health nurses, can anyone pop on and tell our audience tonight how they can refer patients to the local health department for the appropriate vaccines? Can anyone add that to the group right now, or?
Dr. Moore, may I
Yes,
jump in?
please.
Oh, you don't have to see my pen here. I'm just going to jump in. I got two different cameras going. I was going to step on and say that to answer your question first, contact health department, any of them, anywhere in BDH, and can depending on what day that they tend to do them. Some do them every day, some do them just one day a week, can handle that. They can also contact pharmacies, like you said. The biggest thing about the influenza vaccine is that we don't have the funding this time to do the pods or the big flu clinics that we used to. Not this year anyway. Those were related to the CDC's funding of separate vaccines that were not chargeable or we didn't charge for, and that relates back to 2001 and the concerns for anthrax, and that the influenza vaccine was a convenient way to practice throughput in the event of some other type of an alert, and part of the Strategic National Stockpile plan. What we have now is we do have vaccine, but it's with some rare exceptions, it is chargeable, either Medicare or to insurance. There are some vaccines for children of VFC that are a special a select group that certain children do not have to pay. And I don't remember all those details, but for adults and others, just again, then contact the health department and set up a time and a day.
Thank you.
Dr. Baracco, you might have other comments from your far and wide discussions, as well as you in the beautiful Shenandoah Valley.
I think wherever you get it, I'd love to see the most people get it where it's most accessible. So if you're at your primary care doctor and they're offering it, get it there. At the health department, Dr. Spillman noted the Vaccine for Children program, or call any of your whichever health department is closest to you, and usually that is available by scheduling an appointment. And there's also pharmacies. Like, frankly, you can make an appointment at many of the retail pharmacies. There's frequently web apps, or just call. And wherever it's easiest for you to get one, I think that's the best place to get a vaccine. And that's the other question I didn't answer. Now is the perfect time. The season hasn't started. You shouldn't wait for the season to start. If patients frequently ask that, they want to make sure it gets started before they get their vaccine, but preferably they get it now.
Any other questions or comments for Dr. Bracco? Well, Dr. Bracco, we appreciate your doing this one and the previous talk. You do a great job. Thank you so much. Well, we'd like to thank everyone for being on the call tonight, particularly Dr. Spillman and the public health nurses and healthcare professionals that joined us this evening. Let me remind you that November 7th, we'll have the first in the 2 programs on substance abuse, poison control, management, and so forth. So I hope you'll be with us for the program that evening. Otherwise, try to stay warm and dry this evening. Have a great evening, and we look forward to seeing you back in a week or so on November 6th. Thanks so much. Bye-bye. Good evening.
Hi, thanks, Dr. Moore. Thanks, Mary Kent.
You are welcome.
Bye-bye. Thank you.